So I think we're going to start backwards now, and I'm going to say my welcome slides after the first presentation. The first presentation is by John Ward. Of course, John is the director of the Global Hepatitis Elimination Task Force for Global Health, and he's professor of public health at Emory University, and he's well known to all of you. And unfortunately, he could not make it, so we're going to listen to the first presentation on the United Nations Group of Friends to Eliminate Hepatitis.
Hello, I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. I regret I'm not able to attend COLDA this year in person, but I'm happy that my colleague, Lindsay Heber, will be joining you there in Dar es Salaam, together with two of our collaborators from Nigeria and Malawi. But I am happy to participate virtually and to give you an update of the development of a UN group of friends to eliminate hepatitis. I was made aware of the concept of a UN group of friends in speaking with colleagues at the WHO office in New York City, where I became aware that member states come together in group of friends to address issues of common concern. And this concept developed several decades ago to help the UN Director General resolve political conflicts, beginning with Central America and then in other parts of the world. And with the demonstrated success of this collective influence through group of friends, the number of group of friends grew, as well as the topics that group of friends were seeking to address. And currently there are about 10 UN group of friends focused on matters of health. I just gave you a few examples on this slide. And altogether, the UN group of friends is really seen as a way of democratizing the UN process by helping smaller countries have greater influence by coming together than they could individually. And when I heard about the group of friends, it really brought to mind for me our efforts of building national commitment toward hepatitis elimination. It's long been recognized how building national commitment is very important to successful disease elimination efforts. We call this out in recognizing the essential components of effective hepatitis elimination programs. And we have demonstrated success of national commitment, greatly accelerating progress toward hepatitis elimination in countries such as Egypt, Georgia, China, as shown here. So I really began to get a vision of how we could have a UN group of friends to eliminate hepatitis, which had not been previously developed, to bring countries together, help them share lessons learned, help them become more aware of what's going on in different parts of the world, just be better informed about the values of hepatitis elimination and how goals for hepatitis elimination could be achieved. And begin looking at and how other group of friends were organized, recognizing that a UN group of friends are really developed by the missions within the UN. So those are the members. But then you can also engage other partners within the broader group of friends activities. Again, provide an opportunity for information exchange, increasing understanding and awareness about hepatitis elimination, and then looking for opportunities to build that awareness and inform resolutions within the UN and among UN-affiliated organizations such as the World Health Organization. So we began a communications campaign last July and August to invite countries to come to an event on September 20th to launch a UN group of friends to eliminate hepatitis. I want to thank my colleague, Nobel laureate Harvey Alter, who was very helpful in communicating those invitations and speaking at the event, as you'll see here in a moment. We had about 12 countries come to and speak at the launch event, and I think representing the value of a group of friends to engage other partners, a number of other partners also attended, some of whom also spoke. short video that captures that moment last year with the launch of the UN Group of Friends.
We are very glad to share our experiences in this regard.
Egypt expressed the full support to the Group of Friends and the opportunity to lead the effort for the first year.
Ghana, therefore, is very happy and willing to join the UN Group of Friends to eliminate hepatitis.
First of all, let me express my sincere gratitude to Dr. Ward and Dr. Alter for inviting Georgia to join the initiative to form the United Nations Group of Friends for hepatitis elimination.
I'm very honored to present at this event. Thank you very much for having the opportunity to present here.
We are willing, able, and are here to be part of this friendship circle.
The time has come for decisive collective action, which is why we appreciate this gathering.
We will strongly support forming a group of friends for hepatitis elimination. We hope the group will be launched successfully and the WHO 2030 hepatitis elimination goal will be achieved.
I hereby endorse the solemn commitment of the United Republic of Tanzania in joining the UN Group of Friends to combat chronic viral hepatitis.
Sierra Leone is willing and happy to join the Group of Friends for the elimination of hepatitis.
It doesn't happen very often that we have the opportunity to eliminate a disease that has taken countless lives because there is a safe and highly effective cure.
Friends also presented opportunities to highlight health diplomacy. Egypt announced that they were in discussions with Ghana to begin to provide ACV medications at no cost to the country for treatment of persons with hepatitis C. Following the launch event, Egypt, which accepted leadership of the Group of Friends, the ambassador to the UN, formally sent out a letter inviting all missions of the UN to participate in the Group of Friends. The coalition took on the responsibilities of a secretariat for the Group of Friends, with the functions outlined here, and we appreciate the support of the John C. Martin Foundation to help us accomplish these activities. In response to the ambassador's invitation, about a little over 30 countries expressed interest in joining the Group of Friends. The health diplomacy announced at the launch event flourished with the development of a Stop Hep C campaign in Ghana, with the support of the Egyptian donation of ACV medications. As shown here, the Egyptian ambassador is providing the ACV medications to the Deputy Minister of Health, an event held in March in Accra, Ghana. So I think that's an example of activities that were generated by the Group of Friends. We've been able to comment on documents at high-level meetings, such as the one that will be held for universal health coverage at this year's UNGA. It spurred national promotions in Ghana and in Tanzania. Helped the coalition develop new relationships with an expanded number of countries. It's expanded our relationships with WHO, as this Group of Friends will be affiliated with the WHO office in New York. And I think it will continue to create those opportunities for partnership development. Looking ahead to this year's UN General Assembly, we will convene the second meeting of the Group of Friends on September 22nd, aligning with the overall theme of the UNGA. We will be seeking to continue to strengthen that global solidarity for hepatitis elimination, with a focus on integrating hepatitis services into routine health care in the context of universal health coverage. Also, we'll focus on the achievement of the UN Sustainable Development Goal for hepatitis B elimination among children, with examples of countries implementing hepatitis B, birth dose vaccination, and other efforts to eliminate mother-to-child transmission. Also this year, the permanent missions to the UN of Chile and Portugal will be joining the leadership circle together with Egypt. And we've already begun to receive confirmations of countries that will be coming, many of whom will be speaking at the event. This event, will be live streamed for those that are unable to attend in person. So altogether, even though it's less than 1 year old, I think the UN Group of Friends is a promising new way for us to build national commitment for hepatitis elimination. I think we have some early examples of success as we continue to learn how the Group of Friends work within the UN system and how we can begin to use that as a platform for broader engagement of other partners. Please stay abreast of the Group of Friends activities by coming to globalhep.org, to the webpage devoted to the Group of Friends, and follow those activities in our newsletter. I look forward to working with you all to eliminate hepatitis in Africa and globally. Thank you.
Dear members, we warmly welcome you to Tanzania, and we appreciate for your commitment to visit our country and join our congressional effort for the war against viral hepatitis and liver disease. I have the honor to invite our international chair, Professor Al Sayed Manal from Egypt, and he will give a welcome note. And then afterwards, she will do some introduction of our colleagues from WHO, CDC Africa, and the rest. And then I'll take the floor again to introduce our local guests. Welcome, Manal.
Good morning, and thank you very much for your patience. I would like to welcome you all. I would like to welcome all the attendees. Thank you very much for making our conference bigger, both in person and virtually. And I think our society now is going to grow even further and include more people, more physicians, more infectious disease specialists, more hepatologists, and I hope in the future as well, more pediatricians. So I would like to first thank my co-chairs, Professor Wendy Spearman, Professor Mark Nilsson, Professor Wagasha, of course, the local chairs, and Professor Jaka from Tanzania. I would like to thank the organizing committee. As you can see, it is representative of Africa, both Anglo and Francophone. I would like also to thank the scientific committee. We have a very large scientific committee who advises us on the program, and they attend the regular meetings as well. So this year we have in person 293 who are registered, 177 registered virtually, and we're still getting more registrations. We have representations from 46 countries, and we had 117 submitted abstracts, 20 were selected for oral presentation, and 96 as posters. Our program, it's opening, as you heard, of course, we had the early morning WHO session, which was really very interesting and very interactive, and we've seen examples from different countries. In session 1, we have hepatitis elimination monitoring and screening, diagnostics, and we have a symposium on the path to person-centered care for people living with viral hepatitis. Session 2, we have clinical management of viral hepatitis, and then we end day 1. Tomorrow, we have in the early morning a scientific writing workshop, moving from abstracts to a publication led by Robert Brierley, the editor of Lancet, Gastroenterology and Hepatology. We'd like to thank him for being a consistent attendee of COLDA and supporter for Africa. Session 3 on monitoring of liver complications. Session 4 on management of liver complications. Session 5 on management of liver disease, abstract-driven presentations. We have Session 6, multidisciplinary care for HCC, management update, and we would like also to thank ASLD for supporting COLDA, and the role of multidisciplinary approach in resource-limited settings. That's SOLDA supported session, and I would like to invite all those who did not sign for SOLDA yet, the Society on Liver Disease in Africa, to register for free. On day 3, we have the Meet the Expert session early in the morning. We have session 8 on the hidden danger of alcohol and NAFLD in patients with viral hepatitis. That's also an EASL supported session, and we'd like to thank EASL for their huge support also to COLDA over the past 5 years actually, and supporting also SOLDA. Best of posters, and then the last session would be on steatotic liver disease, and then closure of the conference. Please submit your questions through the live Q&A widget, and please click the live support icon for any technical assistance. That's for both the personal and virtual attendees. We would like to thank our supporters, in bronze level Biotest and Gilead, and then we have one of the principal supporters is Viatris. We have media partners, the Lancet Gastrohepatology and HEP, Your Guide to Hepatitis. And those are all our endorsers. And of course, I should not forget all the soldiers behind the organization of this conference, the team that really made this conference happen and made it happen every year. I would like to thank Wilco, Karen, Brenda, Magda, and everybody who worked on this, because really they work very, very hard to make this conference successful, and they respond to everybody. Please join our society, and registrations for free this year. Next year it's going to be for a very, very small amount. Thank you very much again, and wish you a pleasant, successful conference.
Thank you very much, Professor Manal. Not also to forget the local team that worked hard together with the international team, which we'll introduce shortly. So I have the honor to introduce to you briefly for our local guests who are here, and particularly our guest of honor that is representing the Minister of Health, Honorable Umi Mwalim, as Professor Rugajo, who is serving as a Director of Curative Services at the Ministry of Health. Maybe can we? Then we have our Chief Executive Officer, who is basically our host for the COLDA Congress. I work on him, Professor Mohamed Janabi. And we have delegates, our Chief Medical Officer, who is representing also the Regional Medical Officer, Professor Dr. Mfaume Rashid. Maybe you can. Yes, and we have our country representative of WHO, Christine, representing the WHO Tanzania. We have the head of institutions from Muhimbili University of Health, Professor Baladia. We have also the head of institution, Jakaya Kikwete Cardiac Institute, Dr. Wane. We have the head Director General of Tanzania Medical Drug Authority, Dr. Bitegeko. Then we have the head of representing the hospitals in Tanzania, Muganyizi Kairuki, and my best friend, high-tech Sai, Dr. Hashish. Least but not last, we have also our mentor who is teaching us, has been for a long time, an Indian friend and colleague in the faculty of COLDA, Professor Batra from Apollo Hospitals in India. I have also my fellow co-chair, Dr. Jaka Mwambi, that we worked tirelessly to make this happen. So with this address, I think I would like to welcome Professor Janabi, who will take a note of address to welcome the guest of honor. Professor Janabi.
Yeah, good morning to everyone. The guest of honor, Professor Rugajo, representing the Minister of Health, Professor Manal Hamdi El Said from Ain Shamsi University of Egypt, all colleagues from abroad, colleagues from Muhimbili National Hospital, colleagues from all other hospitals in Tanzania, the media personnel, ladies and gentlemen, once again, good morning. I hope everyone had a breakfast. And as usual, you bear with me for a minute. I hope people ate breakfast because they were hungry, or was it because it was in the morning? We are dealing with a GI here, so it's a good remark. So don't answer me, just try to consider, why did you have breakfast? Otherwise, I'm pleased to invite you all to this international conference on managing liver diseases, which is held in our country for the first time, COLDA 2023. The conference, as you can see in the program and the presence in the hall here, aims to bring together experts from around the world to discuss the latest developments in diagnosing and treating liver diseases using modern technology. In the pre-workshop, I saw the conference will focus on using endoscopy in Africa, both in the past, present, and the potential future. It will also discuss guidelines for managing hepatitis, in particular hepatitis B and C, the liver failure, cancer, the biliary system, liver cirrhosis in general. As I was introduced, I'm the CEO of Muhimbili National Hospital. And for those who are visiting, Muhimbili National Hospital is the largest hospital in the zone here. We see around 4,000 patients on a daily basis in our inpatients in our two campuses. One is the main one, which the hands-on training is taking place. It's called Lupanga campus. And 30 kilometers from here, we have our second complex. So we have a total of about 2,300 beds. In this particular conference, Muhimbili is one of the few excellence centers for training in gastroenterology. We see about 2,000 patients per month of GI diseases, and we perform over 600 endoscopies per month. So we are very honored to host the conference for the first time in Tanzania. I think I should underscore this. I hope during the conference the prevention part will be discussed, because with the limited budgets most of the sub-Saharan African countries are having, the question of prevention is very pivotal to me. Oh, the camera people, please. You are blocking people behind them. So after the conference, we invite all the attendees from abroad to visit our beautiful country. If you are not aware, Zanzibar is just 20 minutes by plane from where we are. It's only 90 minutes by ferry. While Kigamboni, Kipepeo, and Sunshine Resorts are just 30 minutes from where you are here. It's just across the channel. And the mighty Serengeti is 2 hours away from here. But on your way to Serengeti, please, you can stop over in Lake Victoria Resort and have brunch. But please, just be careful. It's not a zoo park, it's a national park, so lions are everywhere. While in Serengeti, please stay at Grumeti Lodge. I think you can Google. Grumeti Lodge has been voted the best lodge in the world 3 years in a row. Now, allow me to take this opportunity to invite Professor Lugajo, the representative of our minister, Umi Mwalimu, who is unfortunately couldn't attend this meeting as promised because of reasons beyond the scope. Once again, welcome to Dar es Salaam, welcome to Tanzania, and we look forward to learn a lot from you during this conference. Thank you very much.
Good morning. Yeah, I'm proud and privileged to give the speech on behalf of Honorable Umi Mwalimu, the Minister for Health, who could not make it here due to conflicting schedules. Representative of the Regional Commissioner, Dr. Rashid Mfaume, dear representatives from WHO, CDC, AFRO, UN Group of Friends, and it was really heartwarming to get to see Professor Ward. We had an interaction and a good meeting at the UN General Assembly side meetings last year. So it's nice that what we resolved are taking more speed, and it was nice that this could be done in Tanzania. I would also like to recognize the presence of the EDs, Executive Directors of Muhimbili National Hospital, the Moi Orthopedic Institute, Jakaya Kikwete Cardiac Institute, MUHAS Ocean Road Cancer Institute, TMDA, and NEMRI. Equally, I would like to recognize the chairperson of the organizing committee, which I'm told the local team was led by Dr. John Lwegasha, and the international team by Manala El Sayed. Congratulations for all the hard work. We all know. Thank you. We all know what it takes to organize an international conference. So you leading the team that was behind it and making it possible to happen in Tanzania is really appreciated. So dear ladies and gentlemen, protocol observed. First and foremost, I would like to thank Almighty God for this beautiful day and for making this conference a possibility in this land of Kilimanjaro, Serengeti, and Zanzibar. And you are all invited to take a bit of time to look around and visit some of these touristic attractions of this beautiful land. So don't miss it out. Equally, I would also like to thank Her Excellence, the President of the United Republic of Tanzania, Honorable Her Excellence Dr. Samia Suluhu Hassan, the President of the United Republic of Tanzania, for her commitment towards investment in health, and for the Minister of Health for the ability to translate the vision of the President into policies and guidelines. That includes also putting nice guidelines and SOPs and making sure that the management of diseases, the whole chain from promotion to early detection to prevention, but also to treatment, diagnostics, and palliation is intact, and into transforming Tanzania now, not only to be a force to reckon with in the country, but a regional force and a hub for the so-called medical tourism of the East, Central, and Southern Africa. Dear participants, it is true that liver diseases are on the rise, prevalence-wise, but also incident-wise, especially among at-risk population, including IVI, these are intravenous drug injectors, but also other risk factor groups. But it's equally important to realize that due to the nature of the viral hepatitis, the rate of infection and transmission is manifold times highly infectious and can also be compared to, if I remember microbiology well, compared to HIV, it is up to 10⁻³ times more infectious. So we are dealing with a range of diseases, a spectrum of diseases that is complicated. But if I single out viral hepatitis as a cause of chronic liver disease, then we have to pull out together our resources and the unions like these ones, local, regional, and international, to fight against this disease. It is heartwarming that the participants here are a cross-section of stakeholders and enthusiasts for fighting liver disease. That includes gastroenterologists, lab experts, radiological experts, but also scientists, researchers, and policy and planning and advocates against liver disease. So there is no session that is better than this one to discuss about how to combat liver diseases. So I'm so proud, and congratulations to all of you to make it to this conference. As a country, we are pushing hard to make sure that we are investing in terms of infrastructure, in terms of human resource for health, and in terms of expertise to be able to promote against the disease better, to prevent it better, to diagnose it early, to put treatment strategies, but also to palliate for patients who are beyond the treatment realms. I'm informed, of course, I also know that liver diseases can be categorized into infectious causes, non-infectious causes, and cancer-related causes. And the statistics are daunting that out of every 100 population, there are 4 to 8 who are related to viral hepatitis especially. But the risk is twice as much for the high-risk groups that I mentioned earlier. But I'm also told that liver cancer is number 7 in terms of prevalence, but number 3 in terms of contributing to death. And this is not meant to threaten, but to make sure that everyone is aware, and all of us as stakeholders, we should be taking our parts to make sure that we join our forces to combat rising tide of chronic liver diseases. Dear participants, Tanzania is a member of the UN Group of Friends, and it made a commitment to reduce new infections by 90% and death by more than 65% related to chronic liver disease. And this is achieved through vaccination, provision of safe blood, making sure that there is needle injection safety, but harm reduction, as well as care and treatment protocols for chronic liver disease. As I wind up my small speech on behalf of the Minister for Health, I would like to thank all of you for inviting me to take a part in this very academic, research-oriented, but also policy and advocacy-related conference that we believe the resolutions from this will also be a tool for making sure that our policy and guidelines are better as we combat this rising tide of chronic liver disease. Dear participants, we, as I said earlier, are representing a region in Africa that is geopolitically, geographically, and geoeconomically well strategic. So collaborating with Tanzania in any of the health interventions is invited and welcomed, because the effects, especially the positive effects, will be far-reaching. Tanzania is a gateway towards a bigger section of the sub-Saharan Africa, reaching up to 500 million people. So all stakeholders, in terms of diagnostics, in terms of pharmaceuticals, research, and other treatment modalities, are invited to collaborate with Tanzania, and we believe by collaborating with Tanzania, you are collaborating with the entire Africa. Having said that, I would now like to officially open and declare that this 6th scientific conference for COLDA has been officially opened. Thank you so much for listening.
Thank you so much, Professor Rugajo. I am aware that you are a champion for viral hepatitis. You being actually a nephrologist, before you went to the ministry, I remember those days where you used to triage the patient of hepatitis C in your dialysis room, and how you fought for 1 tower for a dialysis machine for the co-infected. So we're in the same boat, and we know hepatitis is a multidisciplinary involvement, and that's why we are seeing a lot of people here. But we would also like really to thank the commitment of the Ministry of the Government and through the Ministry of Health for giving a priority on viral hepatitis in Tanzania. My understanding is that there are a lot of programs the Minister of Health is working on, and that's why we gave her respect to come here, because last time when she was in the Parliament, she really forged the point of care for viral hepatitis. She forged the at-birth dose of viral infections for mothers in Tanzania. And as we speak, actually, we have a national technical working group for immunization that is working on integrating at-birth dose through our antenatal care system. And so many other stuff have been done, but the most great thing is her effort to integrate viral hepatitis care through the National AIDS Control Program. And I think this has been the WHO agenda and the UN agenda to see how we can use the existing infrastructure that we have, to facilitate, care in a simplistic way in the manner of the universal health care, to make sure that the care is available and at affordable cost to all patients that are affected. As you might know, hepatitis is here in Africa. It's the disease of the poor. In the village, they're the ones that are carrying the burden of this. So that effort is really recommendable, and I would like you to send our gratitude for that, and we really appreciate, and we look forward to see even the National Strategic Plan for Viral Hepatitis that is seated there in your desk, sir, is going to be signed. We did the treatment guideline for viral hepatitis. It has to be now activated so that all these healthcare workers around here, they might be able to use it, and all the commitment the government that has. Thank you very much for your presence, and we really feel honored. So after this, I would like to invite Professor Manal to take the delegation with the minister. There is a side meeting that will be going just for a brief. They take points home, and then after that, then we'll see her off. So Manal and the high table and the invited guests, Rama, you'll guide them where they're supposed to be. At the meantime, we'll remain here, and the rest will remain, and Hannah Emmanuel will continue from CDC Africa, will continue with the session. Thank you very much. Let's have a round of applause for this. So, Hannah, yes, please. I have Hannah to invite Hannah Emmanuel. She's the Technical Officer of Endemic HIV, Malaria, TB, and Viral Hepatitis, and the Neglected Tropical Disease in the Division of Disease Control and Prevention of Africa, CDC. Please, have a floor.
Thank you very much, John. Good morning, everyone. I think I'm audible, right? Good morning, everyone. My name is Hannah Manuel Tespone. I'm a technical officer for endemic as well as neglected tropical diseases from Africa CDC of the African Union. I just want to begin with thanking COLDA for extending an invitation to Africa CDC to present as well as attend this important conference. It's a very much of an honor. Next slide, please. Next slide, please. Oh, sorry. Do I have that? Okay. Oh, okay. Perfect, thanks. So I'll begin with a little overview of Africa CDC. Africa CDC is an autonomous public health institution of the African Union, and it was established to support the public health initiatives of member states and strengthen their capacity to detect, prevent, control, and respond quickly and effectively to any communicable as well as non-communicable diseases. So from 2013 to 2016, Africa CDC was developing its modalities and statute, and was officially launched in January 2017. Africa CDC, as a specialized agency, gets its mandate from African Union, and it operates at 3 levels. We have the Secretariat, which is based in Addis Ababa. The picture that you see in the left is our new office that we just moved to. Africa CDC also has 5 regional coordinating centers that are located in the 5 African Union regions, and this RCCs work closely with member states through their national public health institutions as well as their ministries of health. So Africa CDC is currently developing its first internal strategy for HIV, TB, malaria, hepatitis, as well as neglected tropical diseases, spanning from 2023 to 2027. And we're very cognizant that this program has a very broad mandate, and with a lot of stakeholders that are already playing key role in the continent. And that is why we'll follow a series of consultations with partners as well as member states to identify where and how we can better support our member states in a way that is adding value and is not duplicating efforts. And we have so far reached out to several countries, including their civil society organizations, for consultations when it comes to viral hepatitis program. We also have an external technical advisory group members from different organizations that advise the development process of this strategy. So this slide is to show that our strategy and our continental program is not being developed from scratch, but rather building on the existing policies, guidelines, and strategies. And this is to recognize that there are continental as well as global commitments that already exist and that had also gone through their different consultations with experts. And these are strategies such as the AU Agenda 2063, the Africa Health Strategy, the WHO Global Guidelines, and the Cairo Declaration of Viral Hepatitis in Africa. This is a commitment that places the global target of elimination of viral hepatitis as a public health threat by 2030 at the forefront of the political leadership as well as the global development priorities. So Africa CDC has recently launched its Continental Viral Hepatitis Prevention and Control Program, and the purpose of this program is to support the member states to combat viral hepatitis in a way that is building sustainable systems and capabilities that contribute to achieving this elimination goal. And it aspires to work collaboratively and catalytically with all stakeholders to eliminate viral hepatitis as a public health threat in the continent through the provision of coordinating continental coordination mechanism, strengthening the national public health institutions, encouraging local manufacturing of consumables, leveraging on the existing Africa CDC pool purchasement platform to reduce the price of drugs and consumables, by supporting member states in understanding the burden they have of this disease and strengthening their surveillance systems, as well as increasing domestic financing while documenting the lessons learned. So Africa CDC convened a consultative meeting to co-create this Continental Viral Hepatitis Prevention and Control Program, and the meeting brought together hepatitis focal points from 25 different member states, as well as representatives from partner organizations such as the WHO, WHA, CGHE, research and implementing partners, as well as civil society organizations. And the purpose was to create a stage for these experts as well as partners to provide Africa CDC with the feedback on what this program should look like and what it should focus on. And it was also an opportunity to share the experience of on lessons learned and best practices and how best to coordinate the common efforts to eliminate viral hepatitis in the continent. So So the proposed priorities of the Continental Viral Hepatitis Prevention and Control Program are in line with Africa CDC's new public health order. So one of the lessons learned during the COVID pandemic was the urgency for Africa to invest in its health system and the urgency that Africa needed to be self-reliant and self-sufficient. And this is when the new public health order came to be. So this new public health order is Africa CDC's roadmap to a sustainable health outcome and health security for its continent. So, and it's defined by 5 different pillars, and over the next few slides I'll be going through the proposed priorities in line with these pillars. One of the pillars is strengthen national public health institutions. Excuse me, sorry. First thing that we want to do is we want to begin with conducting a situational assessment to evaluate the viral hepatitis prevention and control programs in all of our member states. We have developed an assessment tool to make an inventory of what already exists, and this is including understanding which countries have a national plan or program, which stakeholders already exist that are already present in country and supporting the elimination efforts, including screening, surveillance efforts. This ranges from CSOs, NGOs, public-private partnerships, etc. We want to understand what is existing capacity of surveillance for all STIs, not just viral hepatitis, so that we can understand how to integrate viral hepatitis to the existing surveillance system that is available. We also want to understand whether there is political traction for elimination of viral hepatitis. Second thing is, based on the outcomes of the assessment, we want to support member states to establish, if they don't already have an existing one, or strengthen their national viral hepatitis programs. We have official nominations of 35 viral hepatitis focal points. This is the way we communicate for a smooth line of communication in implementing our continental program. And we plan to work with these focal points as well as member states so that there is a budgeted viral hepatitis national strategic plan, which is included into the broader national health plan, where there is synergies and linkage to other diseases. And as little is known about the prevalence and distribution of HPV and HCV, another priority is to make sure that there is an initial estimate of the prevalence of chronic hepatitis infection in the general population and or the special population, depending on the local epidemiology. And we plan to coordinate with other population-based surveys to optimize the cost of collecting these key data. So in the short to medium term, we intend to conduct seroprevalence survey on HPV in 5 member states, 1 per African region, and the testing will provide us with evidence of the prevalence of HPV in different populations, including those that are affected with the long-term sequel of the chronic hepatitis B infection. And where hepatitis B vaccine has not yet been introduced, this information will provide us with the baseline data that can be used to compare prevalence in similar age groups after introduction of this birth dose vaccine. So this activity will be conducted as a sequence to the situational assessment once that is completed, as the results from this assessment will be informing us on which countries to select. So the third priority is examining what is in place in terms of surveillance for acute and chronic hepatitis to determine how we can optimize this. And in short term, we plan to be setting up 2 sentinel sites per country in 5 member states. However, we plan to scale up and support additional member states as we go along. And as part of our continental program, we intend to develop an African viral hepatitis treatment and care recommendation that is guided by data collected from the African population. And we plan to be working with HepSanet Group, I think, a network of researchers, as you may all know, that was conceived at this very COLDA conference in 2020, and along with member state and partner representations. They have been working to merge database from chronic hepatitis B treatment treatment centers across the continent to study some of the practical challenges faced by clinicians in Africa. And by using this local data, the aim is to develop a locally adapted African chronic hepatitis B recommendation taking the continent's unique viral, human, environmental features into account. The second pillar of the new public health order is investing in public health workforce and leadership program to ensure Africa has the workforce it needs to address viral hepatitis. And we have several leadership programs in place, such as the Kofi Annan Fellowship Program. This is intended for program coordinators to enable them with the leadership skills they need to negotiate in their country, as well as the global space on how viral hepatitis that is a burden in their country can get the attention that it needs. And developing the research capacity is also very vital. And this week, just ahead of COLDA conference, we had a 3-day training workshop where different researchers from 8 member states attended this training, which was a mix of intense GCP training as well as basic research training with a focus on viral hepatitis research. And this is to develop the research workforce so that at the end of the day, the data that will inform the recommendation will be a robust one. We're also planning a phase 2 of this training next month for the Francophone countries. Another aspect of the capacity building is investing on South-to-South collaboration. Countries have a lot to learn from one another's success as well as challenges as they face very similar hurdles, and this is why exchange programs are very important for a collective success in the elimination efforts. And Egypt, being a country who had made a great success and great progress against HCV and is on the verge of eliminating it, where they screened 60 million people and treated 4 million people in just 6 years. With our flagship program, we have started an exchange program where we take member state key experts to Egypt to learn from them and implement it in their countries. So last month, we took 23 experts from 3 member states, including Ghana that Dr. John was speaking of, who are working in different areas in viral hepatitis elimination efforts. We selected these countries that already expressed interest in establishing or strengthening their HCV elimination programs, and they visited different sites like the National Blood Bank, harm reduction NGOs, data management systems, including the call centers that they use to follow up. And they had the opportunity to speak with the Egypt experts on the challenges, the opportunities, and lessons learned on the road of their elimination. And in this exchange program, we're expecting this member state to come up with a roadmap on how they will implement the lessons that they've learned in their country, with specifying what the type of support they would not need from Africa CDC in implementing this roadmap. So we used HCV as an entry point, but the idea, as I explained, is to conduct a needs assessment for multiple endemic diseases so that at the end of the day we could provide an integrated support for the continent. The third pillar is expanded local manufacturing of vaccines, diagnostics, and therapeutics to increase access to life-saving medicines and equipments. So COVID-19 has demonstrated the need for African continent to be self-sufficient in terms of its local manufacturing of drugs and consumables. So on the short term, we are exploring ways in which the Continental Pooled Purchasement Mechanism, the Africa Medical Supplies Agency that had worked for COVID, can be leveraged for viral hepatitis vaccines, drugs, and commodities. And we're working with this AMSP partner together with our partners in WHA, CGHE, and others for availability of a single antigen HPV bird dose vaccine on the continent. But by the long run, and the end game, and part of this new public health order, is to have a local manufacturing of drugs and commodities. And how do we enable regional manufacturing of drugs and diagnostics that we need for our continent? So there is a partnership for African vaccine manufacturing. It's okay. Manufacturing that was established by African Union under Africa CDC in 2021, and this is to deliver on a bold goal that they've committed to, and that is to enable African vaccine manufacturing industries to develop, produce, and supply over 60% of the total vaccine doses required on the continent by 2040, and up from less than 1% that is being produced today. And the great news is HPV is one of the priority diseases slotted for local manufacturing through this PAVM. The fourth pillar is increased domestic financing in health. This is through high-level advocacy. And when it comes to high-level advocacy for domestic financing, Africa CDC has a comparative advantage in that it has a role or mandate to convene experts, ministers of health, even at the stage of heads of states, and we're able to use this advantage to bring together the decision makers of a country and partners and advocate for domestic financing and other aspects. And we also plan to advocate through the African Hepatitis Summit that is taking place in October, as well as the UNGA, UN Group of Friends that Dr. John spoke to, where the Director General will be providing his remarks. And Africa CDC was also part of last year's inaugural of Group of Friends. And the last and very important pillar is the respectful action-oriented partnership to advance all the pillars that I spoke to. So when implementing our program, we'll do it in a very close collaboration that we already have in place, including our partner WHO, CGHE, as well as WHA. We realize that too much vertical investment is very wasteful, and we need to make effective and efficient use of our resources. That is by aiming to have an integrated approach to target multiple endemic diseases. And of course, we have to put the community at the center of this response, especially the civil societies and people affected, the affected communities working to end viral hepatitis. Thank you very much for your attention. And that's all.
Thank you, Anna, for that very innovative presentation. I think we'll keep our questions or any other contributions at the end of the session. And this time I'd like to welcome Lau from Harvard Medical School, United States, who will take us on the promises and challenges of elimination of hepatitis B in resource-limited settings. Your floor.
Good morning. I would like to thank the organizers for inviting me to this very unique meeting and also to this very beautiful country. I will go straight to why we treat hepatitis B. Our immediate goal is trying to suppress the virus. By doing so, we will have parallel normalization of the serum ALT level and also improvement of histological parameters such as inflammation and fibrosis. But the ultimate aim of hepatitis B treatment is the so-called functional cure, which is defined as the loss of surface antigen. Functional cure is associated with further reduction in liver failure rate and also, most importantly, further reduction in liver cancer, which is a significant cause of morbidity and mortality. However, this is an unmet need, not just in resource-limited area. Even with prolonged therapy, with our frontline therapy with entecavir or tenofovir, up to 10 years, the cumulative loss of surface antigen is only 2% in this international real-world cohort of over 4,700 patients. One of the reasons why functional cure is difficult to achieve is because the circulating surface antigen can be produced by both the intrahepatic HBV cccDNA and also the integrated DNA. In the circulation, when we measure the serum surface antigen, we actually cannot distinguish the sources of surface antigen. We and others had found out that E-positive chronic hepatitis B and E-negative hepatitis B behave very differently. Among the E-positive chronic hepatitis B patients, we found that the majority, over 95%, had relatively low level of integrated DNA, less than 50% in the liver. In contrast, over 80% of the E-negative patients had greater than 50% integrated DNA. Furthermore, among the E-negative patients, the integration DNA tends to cluster around the liver cancer associated region, the so-called hotspot. Fortunately, we do have a lot of new hepatitis B therapies in development, different stages of development, to increase the functional cure, either directly or indirectly. However, prevention is always better than cure. And we must remember the hepatitis B vaccine is the world's first cancer-preventing vaccine. What it means is that to effectively having a universal vaccination program, it would be critical to lead to elimination of hepatitis B, especially in resource-limited regions, I believe. ICE-HBV between 2021 and 2022 conducted a survey to evaluate the unmet needs in hepatitis B management. Our aims were to assess the perceived priorities for hepatitis B elimination among the healthcare providers, and also to evaluate the availability of HBV diagnostic tests in resource-limited settings. Among the 178 healthcare workers who responded to the survey, the majority were from Sub-Saharan and also Southeast Asia. Among them, over 55% were specialists, but also about 20% were frontline health providers. Increased hepatitis B screening and optimized strategies to prevent mother-to-child transmission were perceived as the highest priorities in achieving HBV elimination. However, universal hepatitis B screening of pregnant women were only routinely practiced in 59% of Sub-Saharan and 66% of Southeast Asia regions. Other important priorities are increased access to antiviral therapy, increased rate of HCC surveillance, and also optimized strategies to monitor HBV severity. This slide shows the availability of HBV diagnostic tools by region. As you can see in the red bar here indicating the surface ELISA test, Sub-Saharan had the lowest availability, only 50%. However, in the same region, HB surface rapid diagnostic test was available in over 95%. In terms of the PCR, HBV PCR, again, it was unavailable in about 50% of the locations in Sub-Saharan region. In fact, over 55% of those responders said that point-of-care HBV DNA test is necessary in their location if HBV DNA test is part of the hepatitis B management guideline. We all agree that decentralized community-based point-of-care approach for hepatitis B screening and also treatment is attractive and also essential, especially in the resource-limited region. But one must bear in mind that the point-of-care tests need to meet the ASSURE criteria, the WHO ASSURE criteria, which include affordability, sensitivity, need to be specific, user-friendly, robust and rapid, equipment-free or minimal, and also deliverable to those who need them most. With that in mind, there are currently 3 surface antigen rapid diagnostic tests that meet the WHOP qualification: the SD Bio9 surface antigen, Determine-2, and also VICARE. All 3 of these assays require very little sample volume, had a very good detection limit between 0.1 to 2.06 IU per ml, and also have excellent sensitivity and specificity. However, the rapid diagnostic tests are generally less sensitive than the lab-based ELISA tests. They are not recommended for blood transfusion screening for that reason. And also they can have failure rate among those who have very low surface antigen level. For example, treated HIV, HBV co-infected patients with suppressed surface antigen may not be tested positive with the rapid diagnostic test. So these tests can be applied as a screening test and also not ideal for determining functional cure, meaning the absolute clearance of surface antigen. What about point-of-care assay for HBV DNA? The expert HBV viral load assay was developed for point-of-care use. It is a fully automated PCR assay which requires only 600 microliter of blood sample. It has a very good dynamic range of 9 log, and its limit of detection is 7.5 IU per ml, which is very similar to the standard of care PCR assay, which is about 10 IU per ml. And the results can be available in 60 minutes. Kathy Jackson and co-worker had compared the accuracy between these 3 diagnostic PCR, the Expert, Albert, and Roche. They found that 82% of the samples had good correlation to within 0.5 log IU per ml. The greatest discrepancies, as expected, were at the lowest limit of detection. So the office concluded that Expert HBV assay is reliable to make antiviral treatment decisions, to identify pregnant women with high level of viremia who are at the highest risk for mother-to-child transmission. What about in cases that the HBV PCR point-of-care assays are not available? Can we consider dry blood spot specimen and then ship those specimens to a central lab? The advantage of dry blood spot is it only requires capillary finger stick, does not require trained health workers. It uses very, very low blood volume. It does not require basic lab facility or even electric power. And it does not require cold chain for transport or storage. In 2017, WHO conditionally recommended use of the dry blood spot specimens as an option for HBV DNA nucleic acid testing in certain settings. In the same paper, Kathy Jackson and co-workers found excellent correlation between the dry blood spot specimen and the corresponding sera in 53 pair samples with a correlation coefficient of 0.9. Of note, 10 of those dry blood spot specimens were stored at 4 degrees for 3 years. So with that in mind, the HBV DNA levels were still within 1 log between dry blood spot and sera in 85.4%, Obviously, fresh driver spot from capillary blood should be used to optimize the result. So where do we stand in terms of the availability of point-of-care tools? Well, we do have rapid diagnostic tests for surface antigen, as mentioned before. Delta virus is an RNA virus that can coexist with hepatitis B. Currently is in development, the rapid diagnostic test in Europe. What about for disease assessment? We mentioned that point-of-care DNA assays available, but it leads to increased access. Driver spot specimen may be an option in places that does not have the setup. Currently, we do not have rapid diagnostic tests for ALT. We do have rapid diagnostic tests for E antigen, but the sensitivity range from 27% to 95%, so it needs validation and improvement. Interestingly, in one of the studies among pregnant women, the E antigen rapid diagnostic test has a sensitivity of 76% among those women who had a viral load greater than 200,000. It is widely agreed that FibroScan is a very good modality to assess liver fibrosis and disease severity. It is available in portable form, but again, it needs increased access and also need trained operators. What about for monitoring of treatment and also for disease complications? We have portable ultrasound for HCC surveillance, but again, it's not available across all the resource-limited regions, and it requires trained operators. And besides ALT and HBV DNA, as mentioned before, we do need to have quantitative surface antigens. Currently, it is unavailable as rapid diagnostic test. Driver spot is an option, but needs validation. This and the subsequent couple of slides, I would like to offer a potential point-of-care model to prevent mother-to-child transmission. With the availability of the rapid diagnostic test and also lab-based ELISA tests, all the women in the reproductive age and women in early pregnancy should undergo surface antigen screening. For those tested negative should receive vaccine. The ones tested positive should go ahead and have HBV DNA testing and or E antigen testing, depends on the availability of the region, whether it's point of care assay or lab-based assay. It is critically important to also evaluate the disease severity of the pregnant woman, because if they have active hepatitis, they should initiate antiviral therapy and need to be monitored closely during pregnancy. Especially for those who already have cirrhosis, they really need specialty care. Besides receiving antiviral therapy, they do need ultrasound to rule out HCC, and that they also would need an endoscopy in late second trimester and early third trimester to rule out varices, because if there is varices, C-section would be the preferred modality of delivery to prevent variceal bleeding. For those pregnant women with DNA level greater than 200,000 IU per... What's it? Oh, I'm sorry. Okay, very quick. So for those women who have DNA level greater than 200,000 IU per ml, or if DNA is not available, E antigen positive, then antiviral prophylaxis should start at around week 24 to 28 and monitor for compliance. And for the infant, it's very important to give birth dose vaccine. According to the literature, the earlier the better, within the first 2 to 4 hours. HBEC should be considered if it's available. all the infants to complete 3 doses of the vaccine and also have surface antigen check at 9 to 12 months. For the mother, if they are on prophylaxis, I usually continue therapy for 6 months to prevent postpartum flare hepatitis. If they have active hepatitis or planning another pregnancy, then I will just continue therapy without interruption. And I would like to pack with this slide, and I think a lot of progress have been made with the management of hepatitis B. However, much work still needed to develop and implement this community-based hepatitis B screening and also treatment program. And I would like to acknowledge the ICE HBV leadership and also all my co-workers and members of the ICE HBV point of care model group. Thanks for your attention.
Thank you so much, Madame Clau. So I had the honor also to invite Philippa Esterbrook from World Health Organization, Switzerland, who will take us on the next session on a new diagnosis for hepatitis B treatment.
Many thanks, John, and I realize we're behind time, so I'm going to move swiftly. So last year at COLDA, I gave an overview of the new updated hepatitis C guidelines with major new messages on simplified service delivery, decentralization, integration, and task shifting, the expansion to include adolescents and children down to 3 years, and also the introduction of innovations on the diagnostics. That's point of care, viral load as an option, as well as reflex viral load testing and self-testing. So today I'm going to talk generally about the new updated hepatitis B guidelines. It's a long and complex process with WHO guidelines, and we're not yet finally through the process. I think I finally finished writing them last night and will be sending them out for review in the next couple of hours, but we're not able to share the formal recommendations. So what I shall be doing is sharing the general messaging and the opportunities, and we hope to launch these and the key recommendations at least at the Africa Hepatitis Summit at the end of October. So I'm going to start with just really running through some of the distinctive features of WHO guidelines. And this is a key slide to really make clear, because there are a lot of guidelines out there from professional societies, what is the distinctive contribution of WHO guidelines. Well, our particular focus is in low and middle income countries across the range of epidemic profiles, and our target audience is not just the treating clinicians at the front line, but also national program managers. So we're speaking to the national programmatic public health response. And in our general approach, we adopt the public health approach, as was used with HIV, simplified, standardized approaches in order to have the greatest impact, rather than the more individualized treatment approach with professional society guidelines. And we use a very formal methodology that looks not just at the evidence base, but the feasibility, the end user acceptability, resource considerations as well, with a strong recommendation of the program managers and clinicians from affected countries. And this is just a quick schematic of the process. So we identify the topics, define the question, commission the systematic reviews or modeling, and then based on that evidence base, we also look at the overall assessment of benefits and harms, acceptability and feasibility, and values and preferences to end users, to the community, to patients, to healthcare workers, to Ministry of Health, usually through surveys, look at resource use, do a mapping of the landscaping, be it of diagnostics or the drugs, and look at cost effectiveness analysis. And then all this together is used in the formulating the recommendation and then grading, whether it's a strong or conditional recommendation, and then on the quality of evidence. This is how we then feed in that draft recommendations, and that is made by the expert guideline development group. And I think we have two co-chairs. Wendy Spearman is indeed one, with Syed Hamid from Pakistan and a methodologist. And this just shows the breakdown of those on the guidelines development group, the external review group. We really take a lot of trouble to ensure we have regional representation and gender representation. So why the need for updated hepatitis B guidelines? Well, I think a major imperative is that globally we still have a significant testing and treatment gap with hepatitis B. Less than 10% of those estimated to be infected of the overall 296 million have been tested and diagnosed, and only 2% treated, but with significant variations across the region. And bearing in mind the denominator is of those estimated to be in need of treatment, so it's not all of the Hep B surface antigen positive. So just as for hepatitis C, there was an imperative to simplify and make the cascade of care simpler and more accessible. And the guidance has always been perceived as complex, even though when I was involved in the original 2015 guidelines, we felt we were making a major step forward with dispensing with a lot of the complex terminology and language and the need for e-antigen status. And we removed a lot of that, together with the need to absolutely have a Hep B DNA to start treatment. But it was not perceived as enough, and I think on the forward sort of trajectory of continuing to try and simplify. And so this is an example on this slide of the long journey with the progressive simplification of HIV guidelines, and that's been over more than 15 years. With the hepatitis C one, we've done it in a much shorter period of time. So over the period of about 8 years, really moving to a treat-all, dispensing with the need for genotyping, 3 preferred pan-genotypic regimens, down to the age of 3 years being eligible for treatment using the same regimens, simplified service delivery starting with good practice principles, now formal recommendations, and then the adoption of some simplified diagnostics. So another, why the need for updated hepatitis B guidelines? Well, there was a paucity of data from sub-Saharan Africa when we did the original systematic reviews, and so that was a big flag in our last guidelines, where every section has a research agenda, where we said we need more data from sub-Saharan Africa to inform recommendations. And so we need to address regional differences in our guidelines. They're global guidelines, but there is some regional specificity. And in sub-Saharan Africa, distinct features are the significant rate of ongoing new chronic infections, mainly due to the vertical mother-to-child transmission. And we know the low uptake of the hepatitis B birth dose vaccination, with only 12 or 47 countries that have adopted it. And even in those countries where it has been adopted, only 10% is it done in a timely fashion. This will change with this now big new commitment or reactivation of the Gavi commitment to now promote birth dose, covering both the operationalizing of this as well as now probably going to be covering the cost of the vaccine. So this is going to be a really important step forward, particularly sub-Saharan Africa. But there's also other important regional differences in the demographics and the epidemiology by dint of the high birth rate and the high proportion of the population less than 20 years. As a result, with the ongoing mother-to-child transmission, 25% of all Hep B surface antigen positive persons in Africa are in those less than 20 years. And it's only a few percent in China, where they have had for the last 30 years a very effective infant vaccination program. And we know that liver cancers are occurring at a younger age. And the other observation that in the Asia or the Africa context, 75% of Hep B surface antigens have a Hep B DNA less than 2,000. That's around about 50% in Asia. So there's important differences. We have heard already about the access challenge to Hep B DNA, and there was limited data in 2015, but I think the emergence of HepSANET and some really excellent cohorts in sub-Saharan Africa is changing that, and we need to build on that and optimize it. So these were the hepatitis B guidelines recommendations in 2015. Right across the cascade of care, from the staging, the who to treat, the how to treat with what drugs, first line and second line, how to manage treatment failure, treatment discontinuation, the monitoring, including for HCC. And then we had new PMTCT antiviral prophylaxis recommendations, and Daryl has alluded to that in women with high viral load. What we have there on the left are the algorithms, and these of course will be updated in the new guidance. So what are the new directions? The new directions are really for a substantial expansion in the criteria for treatment eligibility, lowering the APRI score and the transient elastography, and also extending to the adolescents in particular. Secondly, looking at the drug regimens. So we already have tenofovir and entecavir recommended as first line, and we were looking at dual therapy. We've heard already in this morning's session that often dual therapy, that's tenofovir, 3TC or FDC, is often more available because it's procured through the ARV programs and for PrEP. And we were also looking at TAF as well. The PMTCT, we know the lack of access to Hep B DNA has limited implementation of that the antiviral prophylaxis in high viremic women. And so we were looking at how we could simplify for some settings that really cannot access the Hep B DNA. And then in terms of diagnostics, just as we did for hepatitis C, looking at the positioning of point of care, viral load, reflex viral load, really super simple approach that it's an automated doing of the viral load whenever you have a Hep B surface antigen. And for the first time, looking at Delta, very important Delta co-infection, who to test, how to test, and the use of reflex. And then finally, simplified service delivery, because we know only by also simplifying can we move forward. So complicated process. This shows all the work that's gone into these guidelines, more than 15 systematic reviews, multiple modeling activities, looking at the impact of changing eligibility criteria, and the same approach to looking at different strategies for giving antiviral prophylaxis, comprehensive landscaping of the drugs and the diagnostics, including the Delta diagnostics, and also some very important surveys that were undertaken by our partners, both ICER, Hep B, with the healthcare workers, World Hepatitis Alliance, Hep B Foundation, working on the community side in particular and the patient response. We did surveys among pediatricians also, and also among program managers across multiple countries through the WHO offices. So key messages, and as I said, I can't share with you specific recommendations at the moment. The key focus now is on who to treat, with really little mention of the who not to treat, and the inclusion of all age groups, including adolescents, that have really not been part of the guidelines in the past. And this expansion in eligibility includes women of reproductive age, be they adolescents or adults, pregnant or non-pregnant. So in terms of mother-to-child transmission, the main driver of new chronic infections, this will address this big concern. And so instead of the stop-start of antiviral prophylaxis, the potential that these women will already be on antiviral therapy for their own health before becoming pregnant. And there are 4 options for meeting treatment eligibility, and it's an and/or. So you can meet all the eligibility criteria for all 4 or just one. And it is estimated this will capture about 50% of all those that are Hep B surface antigen, compared to about 8 to 15% previously. It's applicable to all settings, regardless of whether there's access to Hep B DNA or not. In fact, only one of the treatment eligibility criteria involves hepatitis B DNA. And there's a big focus on the use of non-invasive tests, as there was in 2015. So either an APRI score or FibroScan, and all those with a fibrosis score based on a greater than or equal to F2. These are the group that is the greatest risk of disease progression and morbidity or mortality, and have the greatest impact of treatment. And everywhere should really be able to get that AST and platelet to be able to do an APRI score and ensure that those are prioritized for treatment regardless of what their Hep B DNA level is. So finally, just to finish, because I realize I'm just about at time, the other big focus is on simplified service delivery. And unlike with HIV or hepatitis C, there were many more challenges with looking at this for hepatitis B. There were few comparative studies of models of care, few interventional studies, a lot of different models and different definitions. So the approach we adopted was to, and I think Alex Stockdale, and there was a wonderful group that we collaborated with from Harvard that has worked fast and furious on this, and the work is still ongoing. So a systematic review looking at Hep B models, and then also looking at the HIV literature. And I think very important were the messages that from the HIV literature, because so much is applicable to hepatitis B, that these recommendations from HIV of inherent support being embedded in hepatitis B care, reducing the number of clinical visits, multi-month dispensing, tracking and tracing, and all the simple and low-cost measures, peer counselors, mobile phone text messages, AI, as adherence support reminders. And I'm just going to go straight to the last couple of slides. Key messages from the systematic review were the paucity of data capture on the later part of the cascade. The early part of the cascade, testing, linkage, eligibility, only about a third reported, but the late part of the cascade about whether patients were suppressed, whether they were adherent, whether they were retained, less than 10% were capturing this. So I think with hepatitis B, we've got a big catch-up to do to ensure embedded in clinic practices is this culture of tracking and monitoring the adherence and the viral suppression. And then I think the early results show, not surprisingly, there is quite an attrition across the cascade. People are discontinuing therapy, people are getting lost to follow up. That's obviously much greater in the context of not being on antiviral therapy. Maybe that will improve. And the hospital models being a little bit more mature and developed, having better results than the primary care. But there are many promising models out there, and in the service delivery session this morning, I highlighted the fact that many of those good models are in low and middle income countries with really some innovations and good outcomes, so it can be done. And I think these are some of the different types of models. It's been a valuable process to start to categorize what type of models are out there: hospital-based, integrated, co-managed primary care. And I think going forward to really implement these new treatment recommendations, we need to massively scale up the testing and case finding, be much more ambitious about general population systematic testing, widespread education, and promoting access to training and capacity building. We've recently just completed and published in the BMC journals a mapping of the online training and workshops and a critique of what's out there and available for healthcare workers, and also looking at all the hepatitis-related ECHO platforms and doing interviews as to the challenges and issues, because there's no doubt the ECHO has been a phenomenal contribution to healthcare worker education. Thanks very much, and the guidelines are coming soon. It's been really intense month on the writing, and hope that we can keep it on track and jump all the hoops to get them out by the end of October. And thanks to so many people who've contributed. Thank you.
Thank you very much, Philippa. That was really needed, and I think the session in the morning was really very important on service delivery from different countries, and everybody needed to hear this. Our next speaker is Danjuma Ada. Of course, everybody knows Danjuma. In his bio, he's a Nigerian prince, an accomplished public health expert on a mission to raise awareness about hepatitis, but he's also the president of the World Hepatitis Alliance. And I think being the first African to be the president of the World Hepatitis Alliance, he pledges also to help Africa in elimination of hepatitis. Thank you for being here, Danjuma.
Thank you for inviting the World Hepatitis Alliance. All right, it's indeed great to always be the last to speak when all the energy is down and people want to get out. And, you know, typically community, we're almost at the base of the pyramid, unfortunately. So I'm going to speak about the barriers to implementation, and I'm looking at guidelines, policies, and not finance, which is actually the big elephant in the room, right? But I'm speaking to clinicians and researchers, so let's look at what are the barriers to implementation of elimination of hepatitis, more or less as it relates to the work we do. So, as the World Hepatitis Alliance, like Manal mentioned, we're in over 100 countries, and we are the face behind all the data when you talk about hepatitis, because we are people that we lived experience of hepatitis, and we amplify expertise by experience and the lived experience of people with hepatitis in driving elimination of hepatitis. So this is what I'm going to talk about, and for us to look at the importance of guidelines, very wonderful, policies, programs, very good, but what are the barriers to implementation? And I always say that the guideline is as good as its implementation, right? So there are a lot of barriers before the patient, especially in Africa and most LMICs. So it's good to have all these good policies, but how does it translate into getting more patients treated, into getting more pills and medicines in the stomach of patients is what is of concern to us as patient groups and to us as advocates. The patient faces a lot of barriers in accessing care. Now, guidelines, like Philippa just rightly mentioned, all the WHO guidelines, all the clinical society guidelines are meant to provide guidance in clinical practice to achieve optimal patient outcomes. The main focus, the main target is the patient, right? And for the patient to achieve optimal health, there needs to be the barriers need to be removed so that patients get what they need to get. So access problems in particular in low middle-income countries may jeopardize the target. The WHO has set targets of elimination of hepatitis by 2022 to 2030. But access is a big problem, and this may jeopardize the possibility of achieving these targets. Now, barriers to healthcare is a significant contributor to poor health outcomes and disparities. And so that is why it's important to understand diversity in implementation of guidelines. So promote, and the understanding this will also promote putting people at the center of national responses in the context of universal health coverage of leaving no one behind. Delivery of services also should be people-centered and tailored to diverse populations. I'm happy that most of the WHO guidelines really are context-specific and looks at the unique challenges of regions, unique challenges of where those guidelines should be operationalized. And there are also issues around communication between the provider and the patient, and then when language and culture may hinder such communication. Now, what are some of the major challenges or barriers to implementing beautiful guidelines? Geographic or cultural barriers, rural, suburban. When guidelines are recommending high-level technology, how is that applicable in areas where there is no electricity? How is that applicable in areas where people need to travel long distances? So geographic and cultural barriers, rural, suburban, health beliefs and behaviors, patient beliefs as well as practitioner beliefs. Cultural diversity is often overlooked, sometimes in even engagement of healthcare providers and even provision of services across most LMICs. Language, care, and information. These are factors that need to be considered when implementing programs or even guidelines. Now, what are some of the socioeconomic barriers, and which are the major drivers of healthcare disparities? Lack of health insurance and uninsured or underinsured patients. These are some of the things we have across most of our LMICs. So when guidelines promote the use of some diagnoses, the patients that are to use those services, how would they be able to afford or access the care they need that the guidelines promote? So in most communities, we have challenges about out-of-pocket and uninsured populations, underinsured populations, and inability to pay out-of-pocket, transportation costs, childcare issues, poor education, employment. So all of these are factors that brings about disparities or access challenges across LMICs and Africa in particular. Now, poor education as a barrier. The language of the guidelines and implementation are mostly in English language, right? Whereas if you look at Africa, about 45% of patients accessing care in most of our primary and secondary levels of care barely speak English and will require translations. And less than 40% of health facilities have language translators. Programs and guidelines should have the diversity of people living with hepatitis in mind and should consider this issue of education as a barrier in getting access to patients and people that need care. And in most facilities, nurses or other health professionals sometimes routinely underestimate the prevalence of limited health literacy and also overestimate patients' ability to understand medical information. So the medical information, like I keep saying to specialists, that it's good to simplify languages. A lay person or a patient comes to the clinic, comes to see the specialist. You need to use simplified languages in interpreting or even engaging the patients and the patient community. Poor education is a big barrier. Now, what are some of the other barriers? Resistance to change. For example, the hepatitis B guidelines that will soon be released by the WHO. So people may resist adopting new guidelines or procedures due to fear of change or preference for the status quo. We have this battle of people thinking the guidelines is going to over-treat more people, under-treat more people. So there's always a resistance to change. In the context, for example, of hepatitis B, we have lots of diverse opinions about who to treat, who not to treat, and most often, unfortunately, patients' preferences and values sometimes are not considered. So there's need to really have understanding that there could be resistance to change. People will want to just maintain the status quo. Lack of awareness. If individuals, organizations are aware of the guidelines for their importance, they're likely to implement them. Resource constraints. Limited resources such as time, money, or personnel. Africa is experiencing one of the biggest brain drains we have currently because of diverse reasons. So we might have some of the beautiful guidelines, but if we do not have the personnel, especially in primary levels of care, in secondary levels of care, I can count on tip of my fingers how many friends have left my country of origin, Nigeria. So we have, at secondary levels, we have dearth of health personnel. At primary level, we have challenges in healthcare personnel. So resource constraints could be barriers to implementation and even improving access on guidelines among healthcare workers and patient communities. Guidelines dissemination meetings are important steps to get buy-in across all sectors. So if this is done, it is our belief that, especially across LMICs and in Africa, we'll not only have beautiful guidelines, but we'll have guidelines.
I would like to add also engagement of children and adolescents in the decision. Not only in the decision, but in the knowledge and awareness about their disease. And I've been doing this for many years, and it really works. So the child understands that he's taking this therapy for that, and these are the kinds of procedures we're going to do. So I think that's important also to include as well, to engage children and adolescents in the decision. And maybe also add that to Felipe's presentation. Thank you very much, Felipe, for the simplification and the very, very hard work for many, many months to make this happen. It took really a tour de force and a lot of work with so many people to make those guidelines available, simplified as much as possible to work for low and low middle income countries. But I would like to remind you, for the pediatrics, we have now great guidelines for children, but we still don't have the pediatric formulations. They're not available anywhere. And we need to work on this after hepatitis C with the GAP accelerator to work on the best pediatric formulations that can be available and affordable to make it happen, to make these guidelines implementable. And now we'll open up for questions. Unfortunately, we have only 10 minutes to catch up for lost time. So any questions from the floor? Please. Karen. Here, so mic number 2 and mic number...
Thank you for your talk. My question is directed to the question, the presenter Lau. Is there evidence to say if you have got portal hypertension with varices, go for C-section? And also, at what level is the varices? Small, large, or medium? I just wanted to hear on the evidence to say, in low-income countries, should these patients go for C-section mothers? Thank you.
Question, because I am mindful about the difference in, socioeconomic status. And what we do know is with portal hypertension and especially presence of more than grade 2 varices, in our practice, we will recommend C-section because with the increase in intra-abdominal pressure, the varices can, break, and it can be a medical emergency. So I am mindful. I do understand some of the limitations, but I think. As we invest in the baby, we should also invest in the mother, if possible, so we do not, leading to situations such as this kind of medical emergency. At least if the mother is diagnosed to have varices, ahead of time, if C-section is not available, maybe a beta blocker can be used. I personally have not used the beta blocker systematically because I will aim for the C-section.
Okay, thank you. Mic number 1. Professor Rafael Esteban.
Yes, thank you, Filipa, for your excellent presentation and your job at the WHO with the new guidelines. I would like your comment on the new Chinese guidelines. So the recommendation of treating every DNA positive without any level.
An important question about the China hepatitis B guidelines. We worked very closely with them. We were aware of these guidelines coming out, and we're excited by them. I think they've been in the works for quite some time. I think the world heard much later, but it's probably been about three years, even longer actually, because COVID intervened. I think they're very important and very appropriate for a response in China. And I think their context is that they don't really have to worry about less than 20 or even almost less than 30, because they've had highly effective vaccination for 30 years, and not just good uptake. We're talking about 95, 96, 97%. So they have very few, I think it's, something like less than 2% of their infections are in the younger age groups. So they can basically divide up their age groups and say everyone above this age is who we're going to focus on. They also have access to high throughput lab-based testing. And some of it is qualitative as well. So simply saying positive, negative. And with very large numbers, it made sense to almost go for that qualitative. Anybody with a detectable viral load, rather than fiddling around, was it between 200, 2,000, and to keep it very simple. Having said that, they haven't yet started to implement this. They have not yet started to scale up or determine where and who and exactly how it's going to be delivered. There are some elements that will be funded through the public sector, but actually even that has not been established. So I think they've laid out a vision. I have no doubt that they will deliver, and they've shown that they could test entire, towns of several million in the space of days with COVID. And that's going to be key. Can they do the case finding? So I think it's exciting, but it's important that everything's viewed in context to the epidemic profile, because people think, why can't you do the China guidelines, WHO? We have to accept there's differences in access and to diagnostics, but it's interesting, and we will follow their experience closely.
Mic number 2.
Thank you very much. My question goes to Dr. Danjuma, and thanks for an excellent presentation on looking at the demand side as it relates to barriers. I would have wanted to have you share some more thoughts on the use of community-based platforms in reducing some of these barriers. You mentioned it, but we want to know if you have fears about the utilization of community-based platforms on reducing the barriers of implementation. Thank you.
All right, thank you, Dr. Green. Yeah, I had to buy 3 minutes for the session. I had to rush through, actually. So, yeah, I think I mentioned that there's always conflict when experience comes into contrast with knowledge, especially in developing guidelines, because Philippa would always want to look at scientific evidence and grading in developing guidelines, right? So the community faced a huge challenge in documenting evidence that would fit into recommendations for guidelines development. I'm saying this with a little experience of being on the committee Philippa put on, and it was quite challenging because we barely document evidences of the good things we do from the community. And this is a challenge to all the community people here to really do more of showing evidence of the community work, the values, the preferences, the community awareness and activities that will fit into the grading or the systematic reviews of the WHO. And that is something that we need to really scale, especially across Africa. It was so concerning that there was no data, no good, strong data from scientific evidence from the community to fit into what the WHO wants. And that is a big challenge to all the groups, especially the community groups, to bring more evidence, scientific evidence of the work we do that will really speak to all that we do. And I would say that also that because the scientific community also need to recognize the expertise of patients as experts by experience. Right, thank you.
Can I just hijack a little bit Tanjuma's response, just with clarity? And I think, we had really excellent representation for the community and civil society at the meeting. But just a point of clarification. The scientific evidence with the systematic reviews, the modelling, is just one component. So we are looking at resource issues, issues of impact on equity, programmatic feasibility, and acceptability, which is not necessarily based on formal evidence. We do surveys, and it's making those surveys as good as you can get to really get the patient perspective. So it's not all about the scientific evidence. There really is that balance, and I think in our interactions with other professional societies, they've said, gosh, we don't do that. We don't engage the communities or do surveys. And we are actually now working with some of the other professional societies and have got a session at ASLD where we will talk about how can our guidelines be the same, so we give a global common messaging, and where will they be inevitably different. And we're even sharing some of our reviews so that they can build on what we've done and adapt for their context. So I think this is an important conversation to go on. But it's not all about the scientific evidence. Thanks.
So thanks, Philippa. Professor Maria Buti.
Yeah, thank you for the excellent talks. I think it's very important to focus on diagnosis and treatment, but I agree with Daryl Lau on the importance of prevention. And I would like to ask, particularly for patients and patients' organizations, I think you have an important role in prevention and also increasing awareness in relatives of the high frequency of hepatitis B in families. So I was wondering what you are planning to do to scale up vaccination. And I think this has been also an important recommendation on guidelines, not only focus on diagnosis and treatment, also vaccination of contacts because and screening, because we can find a lot of people living with hepatitis B among relatives of patients. It's for all of you.
Absolutely, Maria, and you know, we have that huge advantage with hepatitis B, unlike HIV or hepatitis C, that we have a vaccine. I mean, it's the greatest tool in the toolbox and is one of the great public health success stories. And there is now 84% coverage, it went a little bit down during COVID, of infant vaccination. The birth dose was the next frontier. And I think Gavi had that prioritized before COVID. That was put on hold. It's now back on. And I really do think major strides will now be made. Not all countries want to do birth dose vaccination, you know. And I think, but that has to be center stage. And the recommendations we will have on expanding antiviral prophylaxis to all Hep B surface antigen positive is a time-limited intervention, because if your birth dose coverage is good, you don't need to do that. But prevention has to be center stage for sure.
So 2 very short questions and very short answers. Mic number 2, and then that would be the final. No. Okay. No. This.
Hi, so my name is Joël Duntio, and I work for Treatment Action Group, which is an independent civil society organization based in New York. So my questions are, one, we know about the Egyptian initiative to support hepatitis C virus elimination in a number of countries. So I'm curious as to if it's possible to integrate this initiative within what the African CDC is doing in terms of viral hepatitis elimination, because personally, I, together with my friend here, have tried to work with civil society organizations in 2 different countries and the MOH to actually ensure that the MOH can follow through this promise and basically benefit from this and ensure that patients have access to care, but we've been stuck at the level of our MOH. So, and I'm from Cameroon originally. So just to say that we've tried with 2 different countries, I won't name the countries, and we're kind of stuck at the level of the MOH. What can the African CDC do in order to actually make sure that countries take advantage of this commitment from the Egyptian government to promote access to HCV treatment? Thank you.
Thank you for that question. I completely agree with you. The importance of civil society organizations are very, very vital, and that is why I mentioned in one of our pillars as respectful, action-oriented partnership is putting civil societies, organizations, people who are living with this disease and working to fight against this disease are at the center of the action. And what I can say, what Africa CDC could do is one of the biggest advantage that Africa CDC has is its advantage, the mandate that it has to convene at a high level to advocate for the things that are very important. And this is why even in the in-person consultations we brought the civil society organizations from Uganda and to speak on what they've done and the success stories that they've done to support the member states. So this is what we can do, and this is how we can give civil society organizations the voice that they need. I hope that answers your question.
Thank you. One last very quick question.
Thank you very much. Dr. Janvier Serumondo from Rwanda Biomedical Center. My question is addressed to Dr. Philippa. I'm coming back to hepatitis B guidelines. Some years ago, when we were developing HIV guidelines, the treatment was also cascaded. We started by treating people with 500 CD4 and then 200 CD4, and now we are treating all. I guess for HIV guidelines, maybe it will be the same process. So my question is, if a country can be able to avail needed resources, in terms of testing and treatment, because if we are to treat all, it means that testing and treatment related budget will increase. So if a country is able to avail those resources, would you advise that the country can move to the treat all approach versus the current approach of treating people with a DNA which is more than 2,000? Over.
Thank you, Janvier. And I think that was a question that was debated in the guidelines group. It was a question, what threshold of Hep B DNA, should there be a treat all? I think what was very striking in the evidence review part of it, and I was surprised and I had thought I knew the literature, was just the extraordinary paucity of any data for those less than 2,000. And, it was striking, compared with the HIV world, where, of course, we had both trials, we had long-term cohort observational data. And there was part of me that was wondering, what has the world been doing? How can we not have this data? But we didn't. There was one study, one trial with less than 2,000. So that was our starting point. But of course, what we did have much more data on is what is based on untreated cohorts from the past. We had a vast amount of data which showed that those with very low viral loads, less than 2,000, and particularly if they've got completely normal ALT, there's very, very low risk of progression and events over 5, 10, 15 years of those that had long-term follow-up. So that was the foundation, that there was little data on the effectiveness of treating in those low groups, and that's what really you're talking about, the treat all going to the less than 2,000. And they're at very low risk of events. And remember, long-term treatment is not without. It's reassuringly low in terms of renal and bone toxicity, but it's not without. And particularly if you're expanding to include adolescents during periods of critical bone growth. So it is ultimately a weighing up of the pros and cons. And the hepatitis B is not HIV. And coming from the HIV world for 20 years of my life, you know, where the treat all was clearly, I mean, everybody died. Let's not forget it. And so the treat all was, you know, a major paradigm shift that was absolutely appropriate to that model. Not every disease requires a treat all approach. And I think as we move the trajectory towards cure, functional cure, that will change the paradigm. But in sub-Saharan Africa, where, you know, 70% are around, have a Hep B DNA less than 2,000, the implications at the moment of treating all those with very, very low risk of events, not zero, but very, very low, is probably not an appropriate in this first phase of scale up. And maybe if the cure comes along in 5-6 years, obviously there will be major hurdles in access. That paradigm may also shift again. But I think I'm just sharing rather quickly and at rather sort of high level the main debates that went on. But I think it was, you know, people were very, very open about, you know, the strong views held about why not now, and I respect that. But with the WHO guidelines, we have to follow the process. I mean, it's been overused, follow the evidence, but because we know evidence can be interpreted and construed in different ways. But it's not all about the evidence. It is about, but we have actually in the guidelines very important remarks, basically saying, if there are patients, their caregivers, their physician, who feel strongly for other reasons, for reasons of transmission, this is not a guideline about who not to treat. It's a guideline about expansion.
Thank you. Thank you very much, Felipe. I think we need to end this session. We're already very late. And that shortened your lunch break period. I'm sorry. You're going to get at the end of the day the survey, the online survey. Please don't forget to fill out the survey. You'll be back in the room in 40 minutes. No, I think more. So back here by 13:40, please. Thank you.